Thank you, Dr. Taggart, Dr. Torino. I'm sure you're all glad that this will be the last lecture today, so I'll talk about something we haven't discussed much this week yet. And I'll talk about my thoughts, at least, on left atrial appendage closure. This is the projected increase in the number of patients who will have atrial fibrillation in the future. We are, of course, at this point right now, so this is going to be a much greater problem over the next several years than it even has been in the past. There is a relationship between AF and strokes that everybody is aware of. There are about 3 million people in the United States who have atrial fibrillation and about 4.5 million people in the EU who have atrial fib. 2/3 of the AF population are at a high risk of stroke. It occurs at about 5% of the people over the age of 60 and about 10% of the people over the age of 80. This is a distribution of the strokes related to time, related to age, by decades, actually by half decades, and you can see that stroke obviously increases with age. This is the prevalence of stroke in the green bars, and the prevalence of strokes attributed to atrial fibrillation in terms of percentage in the purple bars. So you can see again that as one ages, it's more and more likely that the stroke will be due to atrial fibrillation. Now, if you look at all strokes that occur, about 90% of them are ischemic and about 10% are hemorrhagic. Of the ischemic strokes, 20% are associated with atrial fibrillation. In the United States, that is equivalent to about 130,000 strokes per year. The population in the States and Russia, more or less similar, so I think that the results would be about the same. In the EU, it's about 1.5 times that. And in all places with atrial fibrillation and strokes, patients with atrial fibrillation are 5 times more likely to have a stroke than patients without atrial fibrillation. If a thrombus is found in the heart or anywhere in patients who have atrial fibrillation, 95% of them are detected in the left atrial appendage. Why the left atrial appendage and not the right atrial appendage? Both atria are fibrillating, so why don't we see more pulmonary emboli? Well, if you look at Virchow's triad of hypercoagulability, tissue injury, and stasis, the hypercoagulability of the blood is exactly the same, of course, in the right and left atria. So that's not the reason for the difference in thromboemboli from the left as opposed to the right. Tissue injury, which is sometimes actually caused as a result of atrial fibrillation, again, is the same in the left atrium and the right atrium. So the major difference, of course, is the stasis, which is much worse in the left atrial appendage than in the right atrial. And that's simply a function of the anatomy. The right atrial appendage has a very broad base in comparison to its depth, whereas the left atrial appendage has a relatively narrow base in comparison to its length or depth. In addition to the broad base on the right atrial appendage, the blood coming from the superior and inferior vena cava goes right by, on its way to the tricuspid valve, goes very near the orifice of this broad right atrial appendage. So even when a patient converts from sinus rhythm to atrial fibrillation, the base of this appendage is still washed quite well by the bloodstream, even in atrial fibrillation. It's exactly the opposite situation on the left side, where the blood coming from the pulmonary veins tends to come straight directly towards the mitral valve, and you have a very small orifice of the left atrial appendage and a deeper recess. Of course, the blood flow from the left pulmonary veins is actually going away from the orifice, the left atrial appendage. So for all these reasons, you get severe stasis in the body of the left atrial appendage, but not so much in the right atrial appendage. Now, the gold standard for therapy of course, as we all know, is warfarin. These are studies that were done back in the 70s and 80s, looking at the effect of warfarin therapy on the relative risk of stroke, and you can see that they all had a very positive impact in decreasing the incidence of stroke. They were favorable for prevention of stroke in all the meta-analyses done and all the controlled randomized trial. The disadvantage, of course, is that warfarin can cause bleeding strokes, hemorrhagic strokes, and hemorrhagic strokes are actually more fatal on a number-by-number basis. They're more severe strokes usually than thromboembolic strokes. So in warfarin therapy, what you're doing is you're really running a very fine balance between not having enough anticoagulation and having a thromboembolic stroke and having too much and having a hemorrhagic stroke. Only about 1/3 of patients with atrial fibrillation have sufficient anticoagulant therapy, and that's the big problem with oral anticoagulants is that, especially with warfarin, it's very difficult to maintain patients in the therapeutic range, and it's also difficult to get the patients to take the medicine. If you look at the patient compliance for two so-called secondary therapy drugs, one's statin, one's warfarin, there's a significant drop-off in the number of people who actually will continue to take the medicine on a daily basis the way they're supposed to within the first 24 months of the time they initiate the oral therapy. These data came from the study of over 20,000 patients in Sweden. This is a country distribution of the mean time that patients remained within the therapeutic range in the RELY trial. And these are all the different countries, as you can see here. Just to give you some samples, there were almost 6,000 patients on warfarin. A large proportion were outside the therapeutic range, and there were major variations between the countries. Europe, for example, in Europe, 30% of patients were outside the therapeutic range when they were taking warfarin. In Sweden, 23% were out of the therapeutic range, and in Taiwan, 56% were out of the therapeutic range. So the fact that somebody, that you might have the intention to treat with anticoagulation doesn't necessarily mean you're actually going to treat it the way it should be. Because of the problems with warfarin and other anticoagulants over the years, there have been a number of new devices developed to close the left atrial appendage. The percutaneous devices are listed here. I have the Plato device has been grayed out because it's no longer available. At least it's not in the States. Is it available anymore here? I don't think it's available anywhere. I think it's been taken completely off the market. But the three remaining ones are the Watchman device, which has been studied the most, the Implatzer plug device, and the Lariat device. This is a Watchman device, and we'll talk some more about that in a minute. This is the Implatzer plug, and this is the Lariat device. Surgical devices have been developed as well. They include the Tiger Paw, which is a device that has pins that close off the atrium very well. The biggest downside to this is that once you place it, you can't release it and replace it. And the one that's most commonly used is the AtriClip. And I realize I should disclose now that I have been involved in the development of the Lariat since it was first thought of, and I've been involved with the development of the AtriClip, both of those devices. And I favor those devices, as you'll learn, but I don't favor them because I consult with the companies. I consult with the companies because I favor them. But nevertheless, you should know that. This is the Implatzer plug that's made by St. Jude Medical. This device was actually originally developed to close ASDs and was converted to close the orifice of the left atrial appendage. As I showed you this device a minute ago, the Watchman device is based on a little different principle. It has these fixation barbs on the end of it. Both those devices, of course, are put in through transseptal catheters. The Watchman device has been studied more than any other. The most famous study is the PROTECT AF trial, which was a prospective randomized trial for the FDA that was done by Boston Scientific, who owns Watchman. This is the first report. It was reported in Lancet on this PROTECT AF trial studying the Watchman. It was a non-inferiority trial. It is not checked to see if it's non-inferior to warfarin therapy. The efficacy endpoint was reached so that the Watchman was shown to be non-inferior to warfarin, but the safety endpoint failed with this initial report. A subsequent follow-up on the 800 patients in this series did show that it turned out on longer follow-up to be just as safe as warfarin therapy. The FDA response was that the Watchman was not approved, and the Boston Scientific response was that they started another trial called the PREVAIL trial, which is still going on. But as we speak today, although several hundred of these have been put in as a part of trials, this device still has not been approved by the FDA. One of the reasons it hasn't been approved is that there are significant problems associated with it, as you might expect. In the PROTECT AF trial, there were about 30% of the patients still had some connection between the left atrium and the left atrial appendage. A success, the term success, was defined as a residual connection 3 plus or minus 2 millimeters and no bigger, which means that you could have a 5 millimeter connection, residual connection, and still be considered a success. There have been several. The idea was when this device goes in that it will become endothelialized at the level of the orifice of the left atrial appendage, and that has not always occurred, as is seen here. You see here a residual connection on this 3D echo. This is the Watchman device sitting in the orifice of the left atrial appendage, and this residual connection is a bit of a problem. This is what it looks like when it doesn't re-endothelialize, and these things are quite sizable, and so you'd have to decide for yourself if you want that inside your left atrium. Another problem for the endocardial approaches has been the simple anatomy again. The left atrial appendage orifice is elliptical, and these devices are all round. The size does matter. If it's greater than 2.5 centimeters in size, they're not usually approached. So there is a problem with oversizing, which makes it a little difficult to get these things inside the left atrial appendage on occasion. The epicardial devices, which are the ones I've been involved with, approach it from a different standpoint. The target spot is not exactly at the orifice of the left atrial appendage. It's slightly above it to gain good closure. Now, you can't leave a pouch here that's more than 1 centimeter in length, because if the pouch is more than 1 centimeter in length, it becomes thrombogenic because clots can form in there. But there is some individual variability with these, with the neck of these appendages. But one thing that's almost always true is that there are no pectinate muscles. There are no trabeculae, if you will, in the first 1.5 centimeters to 2 centimeters of a normal left atrial appendage. So we'll talk about these epicardial closure devices, the lariat device, which is the percutaneous one, and the AtriClip, which is the surgical one. The idea behind the lariat is that there's a catheter that's put transatrially that has a balloon on it, and at the end of it, it has a magnet. This catheter, or this sheath, is put through a dry stick in the pericardium, and then a catheter is passed through that sheath that also has a magnet on the end of it, and these magnets join one another. And then over the catheter in the pericardium, the lariat is passed, and it's placed, the balloon is blown up, the lariat's placed proximal, on the proximal edge of the balloon, tightened down, and then cut with a special device. This is what it looks like in cartoon form with the catheter in the pericardium here. You'll see the transatrial, the transeptal catheter coming across now. This is the device that has the magnet and the balloon on the end of it. Well, I'm sorry, here comes the balloon. That's a guide wire with a magnet. And the balloon is positioned in the proximal portion of the appendage. And then a magnet is passed through the sheath that's in the pericardium. And these magnets join one another. The lariat is then passed across the catheter that's in the pericardium and slipped over the atrial appendage down to its base, and the balloon is blown up to guide the lariat down. It's tightened down. There's a special tightening device that removes surgeon variability or operator variability, so it's tightened down to the same pressure all the time. The device is then removed from the inside and it's tightened down further, and then the lariat's removed. And there's a device that's then passed over the end of the suture, and the suture is clipped, and it leaves it like that. This shows one actually being done. This is the transeptal catheter here. You can see where the balloon is. And usually 1, 2, 3 strikes and these things get together. And then you see the lariat coming up over the pericardial catheter, being slipped over the base of the atrial appendage. The balloon's blown up, the lariat's tightened down, and then the inner cannula is removed. After further tightening, you see that there's no evidence of the left atrial appendage at all anymore. Now, after this happens to be a patient who died of other causes later on, about I think 2 or 3 years after the device was used. And you can see where the suture ligature here had completely closed off the base of the appendage. This is the left atrial appendage. And this actually endothelializes on the inside of the left atrium. So it's not necessary to keep these patients on anticoagulation. They're anticoagulated for usually for a few weeks and then taken off. The reason I prefer the epicardial devices is, as you'll see in the next several slides, is that this is the left atrial appendage prior to the time the lariat was applied. And because these epicardial devices devascularize the myocardium of the left atrial appendage, they actually cause the left atrial appendage to disappear with time. So there's no left atrial appendage there. This is 3 months after application of the lariat. And that has connotations from an electrophysiologic standpoint, which we'll get into in a minute. Obviously, endocardial devices do not devascularize or electrically isolate the atrial appendage. The surgical side of this, the one that's been used about 18,000 times now, is the surgical AtriClip. It's made of nitinol so that there's a continued pressure from the outside of the edges of the device onto the left atrial appendage to keep it closed. It can be put on through a thoracoscope as a standalone procedure, but it's more commonly used in cardiac surgery, particularly AFib surgery. It's slipped over the base of the left atrial appendage and then deployed. If it's not deployed in exactly the right spot, you can open it up and deploy it again. This shows the tip of the left atrial appendage here just before the clip has been deployed. And if you look at that, you see a nice pink left atrial appendage. shortly, within about 15 seconds after it's been deployed, that left atrial appendage turns dark blue. It's not blue because the blood inside is blue, it's still red. It's blue because the myocardium of the atrial appendage itself has actually been devascularized. And just like the percutaneous device, this is a view before the atrial clip application, and this is a view 3 years later. There's no atrial appendage there at all. It usually takes about, this is 3 years, but it usually takes about 3 months for this atrial appendage to just go away. So we do have some devices now that will close the left atrial appendage, but there are two issues here. One is, can you close the left atrial appendage? And the second is, if you can, does that make any difference in terms of reducing stroke risk associated with atrial fibrillation? The first study that was ever done to look at that question is called the LAOS study, or left atrial appendage occlusion study. Of course, it was a surgical study. It was done in the early 2000s, was reported in 2005, but it had a lot of flaws. It had two arms in this study. One had surgeons just using an epicardial suture and closing the left atrial appendage from outside, however they wanted to do it, with or without pledgets and so on. The problem in those patients is there was a residual connection with the left atrium in 57% of patients. So even though it makes sense to us intuitively that we can put a suture around and tie the left atrial appendage off, the fact of the matter is you can't. And the other arm was surgical stapling. Again, it's intuitive that you could put a surgical staple on and close the atrial appendage, and then even cut across it and excise whatever part you wanted to. The problem is, with the devices that have been available, it's simply not possible to get down to the base of the atrial appendage. So the problem in these patients was that almost 40% of them failed because they had a residual pouch of greater than 1 centimeter left behind. So not surprisingly, the results of this prospective randomized trial that we were talking about earlier showed no significant reduction in stroke. If you looked at those patients who had actually were closed by either method, it dropped the incidence of stroke by about 50%, but those were not screened. Those are non-randomized patients. I think the best evidence for the fact that that removal or closure of the left atrial appendage does in fact decrease the incidence of stroke comes from our own personal series of Maze patients over the last couple of decades. If you look at all the patients that we've done over the years, and just rather than the absolute numbers, look at all the patients 100%. One thing that was absolutely consistent from almost the time we started was about 1 in every 5 patients who were operated on had a previous history of a thromboembolic event related to their atrial fibrillation. The other 80% had no previous thromboembolic event. So if you think about this, a cardiologist is going to send you as a surgeon 500 patients, all of whom have atrial fibrillation and 100 of whom have already had thromboembolic events. You'd probably have the same response that I was worried about, and that is that we would have a huge perioperative stroke risk in these patients. If you look at the national database, STS database, this is the incidence of major and minor strokes following these different operations here. CABG plus mitral valve is almost 6%. Mitral valve repair and replacement are around 3%. CABG about 2.3%. So if you add a Maze to all these procedures, then I would have expected, especially in this high-risk group of patients, 20% of whom had already had strokes, I would have expected a very high stroke rate. In fact, our perioperative stroke rate was 0.7%. Now, the immediate reaction might be, well, you did a Maze on them so they didn't have perioperative atrial fibrillation. But in fact, 37% of them did have perioperative atrial fibrillation. So you can't explain the lack of perioperative stroke on that basis. I know of no other way to explain this other than the fact that the left atrial appendage was closed or resected in every one of them. If you look at the follow-up to those patients back in the 90s, we didn't have the CHAD system, so we used the system based on all those studies I showed you in an earlier slide, and they were summarized in 1994 in the medical literature. And these 5 risk factors associated with atrial fib were considered to be low risk. In other words, if you had any combination of these factors, then your risk for stroke due to atrial fibrillation fell into the so-called low-risk group. And the thing that really made the big difference was if you'd had a previous stroke or a TIA, which puts you in the so-called high-risk group. This, of course, is where the CHADS system came from, C-H-A-D-S. But at the time we reported this in 1999, with a 12-year follow-up, we didn't have a CHAD system. And so we reported it on the basis of the high-risk, low-risk group. And on the basis of the risk of knowing exactly what category the patients were in when they came to us to have a Mays procedure performed, we could predict what the likelihood was over the next 12 years that they would have a stroke. In the high-risk group on no Coumadin, for example, their stroke risk was about 12%, I guess, per year. And so we knew that a cumulative stroke rate of a stroke risk over 12 years was close to 80% in the high-risk group who were not anticoagulated. If you anticoagulated them, then it dropped down to about half of that. In the low-risk group, the risk was about 50% without Coumadin over 12 years. And if you gave them Coumadin, again, it dropped it by about half. In those days, there was a situation called lone atrial fibrillation, which we don't really use anymore, not to be confused with standalone atrial fib. And it has a risk of about 1% a year, which is about the same risk for bleeding. So most of these people, about half these people were anticoagulated and half weren't when they came to us. But on the basis of what those categories were, you change it to the CHADS VASC risk stratification now, and you see that the risk of stroke, if you're CHADS VASC 1 or CHADS VASC 2 with and without Coumadin, or CHADS VASC 3 or above with and without Coumadin. And on the basis of known published data, there would be a predicted number of strokes in this group of patients had we not operated on them of 68 predicted strokes over that 12-year period of time. What we actually saw following the Mays procedure was 1 observed stroke. So again, this has been attributed by some to the fact that most of these patients were still not having atrial fibrillation. But I think if you combine this long-term data, and Ralph Damiano went ahead and looked at it at 15 years, and we still had only 1 stroke in all these patients, and it was a lacunar stroke. But if you combine the long-term data with the perioperative data, I think it's hard to incriminate anything other than the absence of a left atrial appendage. 65% of these patients were not anticoagulated, but they all had their LA appendage closed. So what are the potential consequences of LA appendage closure? Because a lot of people are concerned about that, and there have been several publications on it and so on. Basically, some of the potential consequences are good and some are potentially bad. There is evidence that there's improved results of catheter ablation surgery for atrial fibrillation. Why? Because at least the epicardial devices, which cause a devascularization of the appendage, can isolate atrial triggers that can induce paroxysmal atrial fib and isolate atrial rotors that can perpetuate non-PAF. The idea is these triggers can be in the left atrial appendage itself, as can the reentrant circuits that sustain atrial fibrillation, and so that the atrial fibrillation can actually originate and be sustained by abnormalities in the left atrial appendage. This is a map from Professor Alfieri's group, Stefano Benussi, who works with Dr. Alfieri. This is a map of the left atrium, and this is the left atrial appendage, and you can see that the earliest onset of a trigger that's inducing the atrial fibrillation is coming from the tip of the left atrial appendage. DiBiase reported in Circulation 3 or 4 years ago on a group of patients in whom they were undergoing catheter ablation for atrial fibrillation, and the left atrial appendage was not targeted in the first procedure, and you can see the incidence of failure. The left atrial appendage was the focus of ablation in the first procedure, but it's very difficult to ablate it with the tip of a catheter. They then went on to isolate the left atrial appendage in the first procedure and the second procedure and got a substantially better outcome from the actual cure of the atrial fibrillation. This is at the one-year results. And he made the statement, which I don't really believe, but in that paper in Circulation, the statement was made that 30% of AF may come from the left atrial appendage. I think it's probably more like 10%, but whatever, it is a positive benefit of isolating the left atrial appendage. We all know that atrial natriuretic peptide is produced primarily in the atrial appendages. I think someone showed a slide yesterday that 30% of it comes from the atrial appendages. And when we first started doing the Maze procedure, for example, we removed both the right and left atrial appendages, and much to our surprise had a horrible problem with fluid retention in the immediate post-op period. As a matter of fact, 4 of the first 6 patients I did had bilateral whiteouts of the chest, and we had no idea why. It just so happened that the person who discovered A&P was the head of pharmacology at our institution in St. Louis. And so we worked together and finally identified that that's what the problem was. We started giving aldactone to all these patients and really going after the A&P, but the fact is that we subsequently learned that if you don't take the right atrial appendage off, which also makes atrial natriuretic peptide, that the changes in A&P are fairly negligible. Either way, Dr. Kim from South Korea has shown that this is a temporary problem, even if it's decreased slightly after removal of the appendage. And finally, there's been a concern about decrease in the left atrial contraction because of removal of the left atrial appendage. This is one I've never bought, and I'll show you why. Several years ago, we developed an operation called the left atrial isolation procedure, in which we isolated, surgically and electrically isolated, the left atrium from the rest of the heart to keep arrhythmias confined to the left atrium and allow the sinus node to go through the AV node and activate all of the other 3 chambers, keep them in sinus rhythm regardless of what was going on the left side. This avoided the need to put a pacemaker in, because prior to that time we were ablating the His bundle and had to put a pacemaker in. So this avoided the need for a pacemaker. It also gave us a golden opportunity to study the hemodynamics of the right atrium versus the left atrium in terms of cardiac output and that sort of thing. So we put a DVI pacemaker in like this, where we put one wire in the right atrium, could adjust the interval between firing into the right atrium and firing into the left atrium. It normally takes about 40 milliseconds for the impulse to get from the sinus node over to the top of the left atrium. And so in a normal sinus rhythm in a normal heart, the left atrium is activated 40 milliseconds after the right atrium. So we knew that, and so we set this thing at 40 milliseconds. Even though the left atrium was isolated, we now had mimicked a normal sinus rhythm. And that's what you see here. This is after a left atrial appendage, after a left atrial isolation procedure. And you'll notice that the left atrial electrogram, the left atrial electrogram is in perfect sinus rhythm with the rest of the heart. Now, we had an aortic flow probe around the ascending aorta for cardiac output. Systemic blood pressure was being monitored continuously. We had a malar catheter in the left ventricle to look at left ventricular end diastolic pressure, and a Swan-Ganz catheter in the pulmonary artery to measure pulmonary artery pressure. So this was in the controlled state with a mimicked normal sinus rhythm. We then suddenly disconnected the left atrial wires so that the left atrium became electrically silent. It was not beating or being activated at all. There was absolutely no change in the cardiac output or any of the preload or afterload parameters as a result of going from sinus rhythm to silent left atrium. We then turn on a rapid atrial pacemaker to mimic left atrial SVT in the left atrium, and again, absolutely no change in the cardiac hemodynamics whatsoever. Now, we're not saying that left atrial function is not important. We're just saying that all of the importance of the contribution of atrial contractility, if you will, to forward cardiac output, all those studies have been done with assuming both atria are beating. In this case, that's not the situation. What we learned is that as long as the right atrium and right ventricle are beating in synchrony, and the left ventricle is normal, it doesn't matter what the left atrium is doing. So our conclusion was that loss of left atrial so-called contraction had no effect on cardiac hemodynamics. So it's impossible for me to believe if the entire left atrium has no effect on forward hemodynamics that removal of the left atrial appendage would have any. So I think that loss of the left atrial appendage contraction has little or no effect on cardiac hemodynamics. Finally, the atrial fibrillation cost analysis. The costs are primarily to prevent patients from having stroke are really not terribly expensive, the most being with dabigatran, which is $3,200 a year. Aspirin has about half that, and so on. Warfarin, not including the monitoring, is even less than that. The problem with the cost of atrial fibrillation occurs when patients have neurologic events. Notice what these numbers look like. A moderate to severe stroke costs the hospitalizations here and long-term $5,400 a month. Major bleeding without residual, hemorrhagic stroke, hospital admissions $38,000. Long-term, it's $5,700 a month. So here's where the costs are. It's not necessarily trying to prevent it, but once it's occurred, once these strokes have occurred, they become extraordinarily expensive. So much so that in this past year in neuroepidemiology, Dr. Andrew wrote that about the prevalence and impact and the economic implications of AFib and stroke. And he made the statement that unless action is taken to improve the detection of AF and reduce its consequences, a considerable increase in the social and economic burden associated with atrial fibrillation-related stroke is likely. And I think that's an understatement. Despite all this information that's already available, this is the guidelines. These are the guidelines published in America. And this statement was made in those guidelines. This was 2006. They didn't change in 2012. Because the left atrial appendage is the site of 95% of detected thrombi, this structure should be removed from circulation when possible during cardiac surgery in patients at risk of developing postoperative AFib. Now, if there was ever a statement ever made that was almost worthless, that's probably it. The reason being, first of all, we have no idea who's going to develop atrial fibrillation. We do 100 people, 35% of them are going to have atrial fibrillation post-op, and there's absolutely no way to know who those are. So we have to anticoagulate all of them. But the importance of this statement, the reason I put it on here is that clearly the experts recognize that the LAA is in fact the main source for stroke associated with atrial fibrillation. So it seems to me they're missing the point, because this is a very highly selected group of patients. And my question is, what about the 3 million patients who already have atrial fibrillation? Shouldn't we be looking at maybe a statement similar to the one they made? There has been a recognition of the problem by surgeons and cardiologists over the last few years. These are the number of publications in the literature, the entire literature on the left atrial appendage from 1948 through 2011. And you can see that there's been a huge increase in the number of publications, roughly by decade, by 2 decades in some cases. So there's been a much greater interest and the left atrial appendage in the last few years. I suspect the next bar is probably going to be off that scale because a lot's being written about the left atrial appendage now. So who should receive left atrial appendage closure? There's no real answer to this. I can give you my opinion. Most people agree that patients with atrial fibrillation who cannot take anticoagulants should have their left atrial appendage closed if it's not a prohibitive risk. The problem with this is that none of the devices have been approved. None of the endocardial devices have been approved yet. Both of the epicardial devices have been approved by the FDA, but none of the catheter devices yet. Patients undergoing catheter ablation for atrial fibrillation, the reason this has not been done routinely in the past is because of what I just said. The devices have not been approved. But I think once they are approved, they'll be used quite a bit. What about patients who have atrial fibrillation who are not candidates for intervention, either catheter intervention or surgical intervention? Would it not be reasonable to at least take their risk of stroke away by by closing their appendage? These patients are frequently treated by His bundle ablation, pacemaker insertion, and now can be treated with these endocardial devices to hopefully get them off of all drugs. And these people are usually very elderly and lead sedentary lives, and the only real risk they have is to have a stroke secondary to their atrial fibrillation. This is by far the largest group of patients in any society, Western society. Patients undergoing cardiac surgery with a history of AFib. If they've had a history of AFib and you're looking at the left atrial appendage, then it seems reasonable to close it. This is not standard of care. This is not agreed to by everybody by any means. But I'll just tell you, if I'm here and in any of your cities anytime and you have to operate on my heart, please clip my left atrial appendage. Just do me that favor, okay? You hear that, Leo? So what about all patients undergoing cardiac surgery? Well, that's a question. There's certainly no evidence for that. It's going to take a large study to determine whether that would be the case. There is better evidence, however, for closing it in everybody who has a mitral valve operation. So these are the kinds of questions that you younger people in the audience are going to have to be answering over the next few years. There's a recent study in which 2,850 patients had pacemakers implanted for heart block and bradycardia. And, you know, they were pacemakers that continuously monitored the status of the heart. And out of that 2,850 patients, a substantial number of them had silent atrial fibrillation. These are people who had never had a history of atrial fib, and they only were found to have atrial fib on these monitors. In that 2,800 patients, there was a cumulative stroke rate of 13% over the 3 years they followed them. It was a little bit over 4% per year. So that's another area that needs to be looked at sometime in the future. So in summary, proper closure of the left atrial appendage virtually eliminates stroke associated with atrial fibrillation. Left atrial appendage closure with epicardial devices may improve the results of catheter ablation and surgery for the treatment of atrial fibrillation. There are no known documented adverse effects of closing left atrial appendage. The left atrial appendage closure in patients with atrial fibrillation will almost certainly reduce the future health care costs. And perhaps, I'll just put this in as a stinger, perhaps we should close the left atrial appendage anytime we can get our hands on it, because that's what I think we should do. Thank you again for the privilege of speaking.
Thank you for that excellent overview of both the pathophysiology of AF and the potential importance of LA closure. How much would it cost per patient as a standalone procedure with your epicardial device?
The epicardial percutaneous device is quite expensive. The epicardial clip, I believe, is about $1,200. I believe that's what the clip costs, somewhere between $800 and $1,200. I don't really know the answer to it, but I do know that the percutaneous lariats It's not as expensive as the Watchman or the implants. Well, I don't know what the implanter does. It's not as expensive, I believe, as the Watchman, but it's quite a bit more expensive than the surgical closure.
And including the hospitalization?
Oh, I don't know what that is, but the person is Octavio here, Alfieri? Did he? Oh, he left.
Yeah.
Okay. Well, the person who's who's reported the standalone thoracoscopic closure of the left atrial appendage is his associate, Stefano Benusi, and I don't know anybody who's really done it on a routine basis in the U.S., so I really don't know what the cost are.
Thank you. And is there a proposal to do a randomized controlled trial?
Yes.
And could you tell roughly what that would be, how many patients you would?
Well, the proposed study that one of these companies is putting together, I believe, has 800 patients, and they're looking at it over a 2-year period. They'll continue to, to collect data beyond that. It'll basically be 800 patients over a 2-year period. And these are atrial fibrillation patients who will be treated surgically and it'll be randomized to with and without a clip.
Thank you. Any questions from the audience? Dr. Pakiria.
Thank you for this lecture. My question is whether when you have a heart in your hand and you, let's say we're talking about closing the left atrial appendage, do you mean also kids?
Do we what?
Kids, I mean children. When you do, for example, tetralogy or I don't know, VSD, SD, will you recommend to tie the
No, I don't.
appendage?
No, I don't think so. I mean, I actually thought about that question before. It's a good question, but the reason I would say no is that children don't develop atrial fibrillation, and we're talking about strokes associated with atrial fibrillation. Children do develop atrial fib, but only when their atria are huge. But in the standard types of procedures that are done, those procedures may cause atrial flutter and other types of atrial tachycardia, but they don't usually cause atrial fibrillation. So I can't think of a good reason that I would do that in children.
So no.
My answer would be no without any data.
Right.
My answer would be no.
The second question is that when you use this, you overviewed this magnetic device, how about the left circumflex artery? Because, when I do it in my hands, I'm very cautious about not to, I am tying,
Mm-hmm.
and so I'm very cautious about not to.
That's a very good question. If you notice, that device is put in, let's see if I can go back to the right slide. That device, the circumflex coronary artery sits right here. Oh, can I get back on the screen?
Слайды верните, слайды. Его слайды верните.
Yeah, the circumflex coronary artery. Circumflex coronary artery sits right here, okay? And you'll notice that when this thing is put on, they're very careful to put this on with the guiding device above the left atrial appendage. So when this thing slides up, it has a marker on it. It's radiopaque. It has a marker on it. And you can always see where the circumflex coronary artery is. And in matter of fact, it's used as a guide to position the balloon. So you want the proximal part of the balloon to be exactly in line with this circumflex. But you can actually see the circumflex very well. It is a concern, but thus far, how many of these things have been done? About 1,200 have been done, and that's not been a problem.
Jim, I always enjoy your talks and learning from them, and a couple of questions. In your maze procedures, your experience with the stroke was amazingly low. In that series, how were you closing? In other words, before we got the devices, how were you closing the auricle? Were you doing it from inside, outside, transecting? Because obviously the issue was the risk of recanalization.
Right. Well, there was no risk in the first, probably 200, maybe 250, because I did them by passing forceps. We're inside the left atrium under cardioplegic arrest, passing the forceps to the tip of the left atrial appendage, inverting it like this, completely inverting it, and then taking a knife and cutting it off at its base, and then closing it from the inside. Now, when we went from, that was through a median sternotomy, when we went to a minimally invasive procedure in the mid-90s, late 90s, 97, I guess, we went to the minimally invasive, so we did the whole thing through here. I still used cardioplegic arrest, but one of the problems with inverting it, cutting it off, and closing it from the inside is 100% of the time there's a little arterial bleeder on the outside. So at the end of each case, I'd have to lift the heart up and put a little suture in that bleeder coming off the circumflex going into the base of what used to be the appendage. And I realized when I started going from the right side, I was not going to be able to, I could still pull it in, close it the same way, but I'd never be able to get to that bleeder over there. So that's when I changed and stopped doing the cut and sew and went completely to cryosurgery. So at that point, I just put a round 2.5 centimeter cryoprobe right in the orifice of the left atrial appendage, and then left it in place. Now, that isolated it surgically, but left it in place and closed it from the inside. Now, you really have to know how to close the atrial appendage from the inside. A lot of people have the tendency to just put a purse string around it and tie it down. And I equate it to the mouth. The mouth, when it's wide open, is round, so like the left atrial appendage is. But when you close it, it becomes a line, a linear line. And the left atrial appendage does the same thing. When it's wide open, it's elliptical really more than round, but it's not flat. And so think about trying to close your mouth this way as opposed to this way. So what you do is you put some forceps in or Kittner in, and you play with it a little bit to see exactly how it wants to close. And once you find that, I'd put a figure of 8 suture in each corner and tie it down. And then hold tension on it and put a horizontal running mattress in it, tie that down, take the other suture and do an over-running stitch back here and tie it down. So when you finish, you have basically a closed incision that's about that long. And we never had any, at least that we knew of, come back, and we certainly didn't have any more strokes or anything, even leaving them in there. But I think closing the left atrial appendage it requires some thought and some technique.
So just to follow up on that, and also in relation to your excellent talk yesterday, currently, what energy sources do you recommend if one's not doing a complete cut and sew? Are you using cryo? Are you using AtriCure? Are you clamping? Would you advise clamping 3 times? And the other question I have in relation to maze is, whether rightly or wrongly, I've gone, when I do a maze, to put one of the clips on the auricle instead of cutting it or inverting it and sewing it over. So it sounds like you would recommend rather to over-sew it from the inside rather than put a clip, or
No, actually I wouldn't, because Nevad has had some experience, has written it up, where he's put the clip, the AtriClip on the outside, and then, before he did the study, and then has gone inside and looked at it. And that thing is absolutely closed, and it's just a slit like this. It doesn't leave a pouch or anything. And I think that I would probably do it either way, but I think that the one way you can be absolutely certain that you're closing the left atrial appendage is put a clip on it.
Yeah.
Those things are actually, I think, better than trying to suture it closed. And they're also probably safer because of the circumflex coronary artery. I think that if it's not cost prohibitive, that's the proper thing to do when you're doing surgery. In terms of the devices, I think that that's all changed a great deal in the last 5 or 6 years, let's say since about 2005 or 6. And what's changed is that I thought pretty much all the RF devices, and there weren't any cryo devices really available prior to that time. I sort of jury-rigged some, but I've used cryosurgery for years, and I prefer cryosurgery, but you have to know how to use it, and very few people use it correctly, and it will fail if you don't use it correctly. But about 2005 or 6, the companies made, I thought the devices were absolutely lousy before that. Since that time, the RF clamps are very good. I would never use a unipolar energy source of any type because I just don't trust them. The pins and rails and all those things, I just don't trust them to have long-lasting effects. But the cryo probes, both the one that Medtronic has and the one that AtriCure has, are both excellent cryo probes. And if a cryo probe fails, it's because the surgeon didn't know how to use it, because they won't fail. They're just as good as cut and sew. The bipolar clamps, I think both the AtriCure clamp and the Medtronic clamp work fine. The fact of the matter is I've always had a little trouble with some company giving me a device and saying, clamp this, and watch this little thing change, and then you know you're transmural, but oh, by the way, clamp it 3 times, you know? And I finally came to realize that it's not that you haven't gotten transmural. I think you probably do. But there are always little areas at the ends of that clamp that you may not be transmural. So what you try to do is position it a little differently, change the angle of it a little bit, and so on. And that's the main reason for putting it on 3 times. But I do think you should do it 3 times. And if you do that, it's very rare now for those lesions to fail.
Thank you. Amazing body of work you've produced.
Thank you.
Yes, of course.
I've been many years ago, maybe 10 or 15 years ago, at the first meeting, first summit for the wild disease, you know, huge one in Chicago, okay? Mm-hmm. And the last day there was kind of controversial meeting talking exactly about thrombosis of LA, and they were showing very different approaches, you know, clamping and tying and cutting and suturing, and they showed the new thrombus in all cases. So my question is, will you recommend then, if that's an adult patient, I do surgery and I tie or I clamp, or it doesn't matter, will you recommend then for some time to use anticoagulation?
Yes. We usually anticoagulate these people for about 6 weeks. And then take them off anticoagulation. But I think with the people that get the Watchman device were anticoagulated for 45 days, and they were in a 45 days. They were in a prospective randomized trial against warfarin, but everybody got warfarin for at least 45 days, and several of the patients were kept on it. So. Yeah, I think that's the safe thing to do, regardless, and certainly with these epicardial devices, because you never know for sure that you might not have a little tiny pouch or something. So I think it's wise to anticoagulate them for maybe 6 weeks, and that's general practice.